Okay, so second half of the lecture, and again, I apologize for not recording the first half, but I will post the PowerPoints to the announcement page. Within those PowerPoints, there's those videos to watch, and I'll separate those so you guys have that as well in your Module 3 announcement page. Yeah, Module 3. So you guys can go back and review that. And again, there's questions, you know, within your Vocarialist book that you can go through and all of that. So, so make sure you guys go back in and read that. So let's go on to skin integrity and immobility. So you guys are going to start off in Cornerstone, right? So you guys are going to see this with, if not all of your patients, right? They're going to have some sense of immobility or limitation of their mobility. And what happens when somebody is immobile and not able to either move, right, or walk? What starts to happen to them? What are they at risk for? Skin wounds? Yep, absolutely. We're worried about skin breakdown. Falling, absolutely, Lauren. That's huge. For patients that are immobile, right? If they're just lying down, they kind of get like to where they're either weak, right? They can't stand up anymore. They could have orthostatic tension. Do you guys know what orthostatic hypotension means? Somebody has orthostatic hypotension, low blood pressure, right? So hypotension is blood pressure, low blood pressure. What does orthostatic mean? Exactly, I can't talk. Their blood pressure drops with position changing. So if you ever get asked to do an orthostatic blood pressure check, you're always going to start off with your patient lying flat. You're going to let them sit there for about a minute or two and let them kind of relax and kind of, you know, adjust. You're going to take their blood pressure and their heart rate. You got to take both, right? Then you're going to have them sit up. Same thing. Give them a few minutes, let them get oriented, take their blood pressure and their heart rate, and then have them stand up. Obviously, if they get dizzy at any point, you want to stop and say, yeah, they've got a positive orthostatic blood pressure. So that means their blood pressure usually drops as they stand and their heart rate goes up. Okay? So yes, so when somebody's immobile, they can definitely have that and be at risk for falling. Okay, so let me go here. So kind of know the difference. So skin integrity, right? What does that mean? So our skin is our largest organ, right? It protects everything. If you have skin integrity issues or the skin integrity is not intact, they have any kind of blistering, right? It can go, there's different stages of wounds, right? And so the slightest little stage or scratch can affect everybody differently, right? So we talked about our geriatric population and what they're at risk for, and their skin is so fragile, right? Any little bump can cause a massive skin tear, right? If you guys have ever seen a geriatric or an elderly patient come in and they have a skin tear, they are so nasty and they bleed and they bleed and they bleed. And it's just the thin little layer of their skin just rips right off of their arm or wherever they bumped, right? You can't really suture it. Sometimes you can, but it's just so thin that we really have to just bandage it up, okay, and it kind of starts to heal. So skin integrity, again, is super important, especially for our patients that are sick, right? Because what happens if their skin integrity is compromised? And let's say you've got a diabetic patient, right? Or you got a renal patient who's on dialysis. What happens with their skin when it breaks down? What happens to their skin? What do you think is going to happen? Why are we so worried? Right, infection, right? So any little thing that can definitely, you know, break that integrity, they can get an infection. And a lot of patients, once they get that infection, they can't get rid of it. okay? Especially our diabetics, right? You talk about a diabetic foot, they can't feel it, right? And they're not allowed to walk barefoot, but they do, or wear shoes that are not fitting appropriately because they'll rub a blister and they can't feel it. So they can go weeks without knowing I stepped on a nail and I still have the nail in my foot and it's caused a huge infection, right? Now they're septic and now they probably have to have their foot amputated. So it's really important to maintain our patient's skin integrity, okay? When they're immobile, this can definitely increase their risk for developing breakdown, right? So they're not able to move about. They can't, if they're lying in a bed, what we do every night, right, is we toss and we turn. Your body does it automatically. You just do it in your sleep. You don't even know you're doing it. For some people that are immobile, for whatever reason, it could just be an acute issue that they have going on, or it could be a chronic, right? So somebody that's a paraplegic, right? They can't move the way that you would want them to in order to prevent right? And so we have to identify these patients and we have to make sure that we are turning them, helping them, keeping them clean, keeping them dry. So there's a lot going on here when we talk about skin integrity and mobility, okay? All right, so we talked about, what we can, how we can do a skin assessment. So let me back up. So if you're doing a skin assessment, right, it's imperative, no matter where you're working at, is if the patient is a new admission to the hospital, or they're visiting you in the clinic, or you're taking care of them in a long-term care facility, they could be there for 5 days. Whenever it's your shift, at the beginning of every shift, I can't stress enough how important it is to do a thorough skin assessment on your patient. You would be amazed at the beginning of your shift, you'll have nothing. And let's say you've got a 5-patient load and you're not able to turn your patient every 2 hours, your patient will develop an ulcer, okay? They will have blistering. I guarantee you it. So if that goes unnoticed for, it could be that next nurse's shift and they can't get to it, you're talking huge complications for a patient. So I can't stress enough how important it is to do a skin assessment on your patient and making sure if they need to be turned, you're turning them. Making sure that we're preventing that skin breakdown, right? Skin breakdown, what do you think will help drive somebody to have some skin breakdown? What do we want to avoid when we talk about skin? Wetness. Exactly, Alice, right? We don't, a lot of, oh, so a lot of our patients will be incontinent, right? And so there's all these different devices out there now. We try to avoid Foley catheters as much as possible. Why do we try to avoid Foley catheters? Why do you think that is? Why do we not like to put Foley catheters? Risk for infection, right? So that's a hospital acquired infection. We caused it. And they're at high risk. Most of the patients that have a Foley in, if we don't take care of them appropriately, are going to get an infection. So they have what's called PureWicks now. It's all these different fancy devices that help absorb any kind of urine or even feces into some type of device that helps keep their skin from getting wet or affected, right? So again, this is something, once you go into your facilities, know what those devices are. They'll still use briefs or depends on them over these devices. But it's important, again, is our patient immobile, right? Do they just need help getting to the restroom? Are they able to walk with assistance? Do they need a walker? So we need to make sure we know what their abilities are and have them up as best right? So if somebody is able to get up and use a walker, we don't want to prevent them from doing that and just put, something on them because we can't get to them in time, right? So we've got to really plan our day out. And when you start to make your nursing rounds, a lot of facilities will say, okay, once an hour, you're going to go into each room and just make sure that they have what they need. So do they have their call light in reach, right? Because their call light's important. If they need something and they try to get out of bed and they're immobile, what's going to happen to them? Trying to reach for that call light. They're going to fall. Exactly. And the last thing that you want to do is have your quality department say, you caused this patient to fall and now he's got an injury because of it. What did you do to prevent this fall, right? We don't like that. We don't like to be on that list. So we have to make sure that we're giving the patients what they need. Do they have everything close to them? Here's your call, like call me if you need anything, call me if you need to get up, right? Do you need to use the bathroom while I'm here? If they're one, as soon as you know you're going to leave, they're going to need you to go to the bathroom and you've already moved on to your next patient. Don't get, okay, let's get up. We're going to do a little bit of walking and we're going to go to the restroom. So you'll kind of get to know what you need to do. But going back to the skin breakdown, we need to make sure that we're keeping our patients clean and dry. Okay. As the patient's length of stay increases, so does their risk for developing skin issues, right? These skin issues are very expensive to treat, okay? The moment that somebody is identified as having skin breakdown, whether it be redness, right, or a blister, all the way down to a deep tissue injury, and we're going to go over what those stages look like, you get different people involved, right? So a lot of places will have wound care nurses. So they'll have to get specific wound care treatment and products applied. They may have to have debridement. So there's a lot of things associated with that you don't want to have to happen as long as you can prevent it, right? Once they get skin breakdown, it increases their mortality, okay? So they're at a higher risk for dying because it causes so many complications, right? Again, we talked about our skin being the biggest organ that we have. It's our biggest protector. So again, once that skin breaks down, they're at risk, and especially if they already have an illness going on, right? All right, so let's talk about this wound classification. So what caused the wound? So there's different layers of your skin, okay? It could be a clean cut, like an incision. It could be a laceration, which is kind of just all over the place. An abrasion, where they kind of like scratch the surface, right? A puncture wound, a penetrating wound, a contusion, and a hematoma. So there's all kinds of different classifications. So I would definitely know this, and they're pretty forthcoming, right? We can kind of get what they're saying or what it is. And it's all how you treat it, right? Because every wound is going to have a different how you treat it, how we intervene. So you might have okay, let me go back. So the first thing that you're going to do is what caused it, or what kind of wound do they have? And then you're going to describe the depth. Okay, so another classification when you're doing an assessment. Is it superficial? Is there partial thickness, full thickness, and a deep wound, right? Or at those DTIs, remember we talked about that, where it goes all the way down to the bone, okay? This happens very, very quick. Within hours, it can go from a little blister to an open wound to now you see some full thickness or down here in the dermis, and then, on day 2, you can see the bone. So it can happen very, very quickly. How would you describe it? So we want to know the location, right? So is it, a laceration on their arm that's about 2 centimeters in length, and it's, superficial, those type of things. So you want to be as descriptive as you can. That's going to help you kind of know, again, give you a baseline of when you noticed it, where you're at, and on day 2, are we getting better or are we getting worse? So they'll be able to stage that. And again, a lot of places do have wound care nurses that are experts in this, and they'll be able to, they kind of take over and do that part of it. But again, some places don't. So this is something that the nurse has to do. Factors that contribute to delayed wound healing. So again, we talked about all of these things, right? So we talked about the advanced age. So our geriatric population are extremely at risk for, once they get a wound, it's hard to get rid of it. Those immobile patients. So anybody that's immobile, any kind of debilitation, right? What other disease processes do you think are acute? Somebody that, yesterday they were walking and talking and doing, working and doing everything completely normal, and now all of a sudden they're completely immobile. What do you think? What kind of disease processes could you guys think about that would cause somebody to be acutely immobile? A stroke, right? Exactly. So that can be very devastating, right? It can completely affect their whole body. It can affect one side. So we got to be aware of, is it the right side? Is it the left side? Do we need to make sure that we're moving them because they can't move that side anymore? So those type of things. They may even have like a loss of sensation, right? So their leg can be completely on a surface that is causing damage to the skin and they don't know it. Okay. So most definitely, and traumas, right? So we can have trauma with spinal cord injuries, right? So they just got complete desensitized at a certain point in their body. They're at risk for these skin breakdowns due to being immobile. Okay. Chronic diseases. So I saw somewhere somebody talked about edema. So that's a huge one, right? So Christian, you mentioned edema up at the top. When patients have CHF or they've got lymphedema or something that causes swelling, that swelling can get so bad that it actually causes weeping of the skin, right? And they have chronic weeping of the skin. It always looks red, it always looks inflamed, it always looks super mad, right? So those people are at high risk for having wounds chronically. Steroid use. So if they're on steroids, that definitely will cause the skin to be at risk for breakdown and tearing really, really easily. Inadequate blood supply, right? So we've got to make sure we got good oxygen. Friction on a wound can destroy the granulation tissue. So if they've got a wound that's healing and there's something that's causing friction on it, so let's say they've got a wound on their buttocks, right? And we are trying to move them up and down in their bed. If we cause that friction or that shearing friction from the sheets onto that wound, we're just tearing that wound right open every time we move them, right? So again, you got to be very aware of the location and what type of wound it is so that we don't cause more damage, okay? Nutritional deficiencies. So those of you guys who have already read your ATI book, your nutrition book, what kind of nutrition deficiencies will cause delayed wound healing? It's a big one. It's a big nutrition factor that we look at when we're talking about skin. Protein, exactly. So somebody, and what lab value are you going to look at to see if they've got enough protein? Albumin, right? Exactly. So if somebody's got already a nutritional deficiency, right? We already know they're severely underweight or they're just not eating. And they've got all of these skin issues going on. And if they haven't done a nutrition assessment and done an albumin, you probably want to say, hey, I think we need to do this. I think we need to draw that, right? That would be huge because we need to replace that. We need to make sure that we're giving them everything that we can to uh, give them the defense mechanisms to have their skin be healthy. Obesity, right? So obesity can definitely cause skin breakdown. Smoking, you're going to see smoking from here on out be part of all the problems, right? If you smoke, you're going to be at risk for every disease possible. So if they smoke, we need them to stop. That's kind of the first thing. If they're generally just in poor health, right? So we have a lot of people with a lot of different multiple factors going on, and maybe sometimes they'll tell you, I don't have any diseases or any medical history. I'm not on any medication. You look at them, you're going, oh my gosh, you're about to be diagnosed with a million things. They may come in just in poor health, right? And then we talk about complications of the wound. So in your book, go ahead and read through those and just kind of know what those look like and what you're going to do. There's a table on page 163, table 11.7, that goes into very good detail about what that looks like, okay? All right, so again, your nursing assessment. So we talked about how you're gonna assess these wounds, right? Where's the location? What size is it? The depth of it? Does it undermine or tunneling? Margin. So it gets very, very detailed. In your book, I would, again, you might not have to do this, but I would know if you do have to do this assessment, what tools you have in your facility to be able to assess that. So they'll have like measuring tapes, and sometimes they'll use cotton swabs to see how far down the wound goes, or does it undermine, does it tunnel, does it go to other places. So there's different ways that you can assess those things. So again, it's in the book, and I think if you look at not only, yeah, table 11.7. But there's also a picture, there's several pictures on here too. So take a look through those, and again, just kind of know what your assessment's going to look like. And then nursing implementation. So what are we going to do? We're going to protect that wound, right? So we need to make sure that we're doing everything that we can to make sure that this wound doesn't get bigger or get infected. So, what does that look like in your facility? Is it dressings? Do they have specific dressings? Is there like ointments that have antibiotics in it? There's all kinds of fancy things out there right now. There's a new one called Mepilex, and it's kind of a padded bandage per se, but you keep it on there. I think you change it out once a day, and it helps heal that wound underneath, but it also helps prevent any friction and keeps it clean and dry. So again, different facilities will have different names for it, but it's basically the same thing. Treat it. How are we going to treat it? Again, dressings. Are they getting enough nutrition? Do they need medication and drug therapy? So do they already have a infection that we need to treat? Negative pressure therapy, so hyperbaric chambers. That's another way that we can treat that. Debridement. So what does debridement mean? What does that mean? You have to debride a wound. Foreign objects in the wound. So it's using objects to remove the dead tissue, right? So there could be different types of debridement. So the worst part, or the worst level of debridement, is a sharp surgical debridement, right? So they actually use like a knife or a scalpel to remove the skin around the edges because they need it to heal appropriately. So on 166, table 11.10, there's types of debridement. So again, good information to know. You don't need to know it all in detail, but just know that that's what it is. We talked about the hyperbaric, okay? Educate. So we need to make sure we're educating our patients. How are they going to care for this at home? Are they going to go home with, wound care, with these bandages, with medications? Do we need to treat them proper nutrition? So do they need to know how to get protein, high protein sources, right? So we need to be able to know what those are. So if you have somebody that does need proper nutrition with a high protein diet, what do you think that's going to look like? How are you going to tell them this is what you need to do? What resources or what foods would you want to educate them about? What foods are high in protein, right? We've identified protein as their need. Lean meats, okay, yep. What else? Beans, okay. In order for that protein in your book, it talks about beans and rice. I know it's kind of crazy. It kind of threw me off when I read that for the first time, but you need to have beans and rice to be able to have a complete protein, not just beans themselves. I swear it's a thing. You guys got to read it in the book. It's crazy, I know. Also too, like dairy products, right? So some dairy products are high in protein as well if they can't tolerate the full meats just yet. So those are other options. So go back in your nutrition, and I think you definitely need to know how are you going to appropriately educate your patient for proper nutrition if they have skin issues, okay? Observe for complications. So what would you look for to start noticing like, hey, this wound's not getting any better, it's getting worse? What do you think you're going to see first? It's the first sign of a complication. Redness, right? Okay. And then if we don't treat it after redness, what's to ooze? Exactly. So it's going to have, it could be serosanguinous, which is kind of like a blood tinged something's going on, right? Could be warm to the touch. Yep. So the warm to touch can actually go first, right before the redness. Might feel that. Then what happens after it starts to ooze? Definitely pain. Yep. It opens, right? You're going to start having that when we talked about the staging, right? So what stage is it at? Did the wound start underneath the skin and we just missed it and now it's open? Is there tunneling? Is there a lot of damage underneath that skin that we didn't catch, right? It won't heal, right? So you're going to, the redder, the meaner it looks, the more infected and the more problems you're going to have, right? And so you're going to see some really mean infected wounds. Um, and when you're in Cornerstone, pay attention to those because I guarantee you're going to have multiple patients with different stages of wounds there. All right. And then when to call the doctor, right? So we don't want them to wait too long if things start to get out of control. We want them to notify them as soon as they, have that warm or that redness, or they start to have increase in pain, right? Don't call us when you already have this huge stage, 5 wound on your wherever you have it. We want you to call early. All right, so when we talk about patients that are immobile, right? So they're not able to move around. So you're going to have these pressure injuries. So when we talk about pressure injuries, those are the bony prominences that are going to be the heaviest on that bed, right? So know your bony prominences. They spelled heel wrong on there. I just noticed that. This came from the book. So heels are a big one, right? So we've got protective devices that you can use to apply to your patients if they're at risk for developing wounds to the heel, right? The knees, if the knees are, on like, you know, um, laying on something else, that bony prominence, right? The lower back, the buttocks, the hips, all of those things are at risk for developing pressure injuries. So what is the number one thing that we can do to help prevent pressure injuries? What can we do for our patients? Reposition them, right? Exactly. How often do you want to reposition them? What do you think? Every 2 hours, right? Every facility has a different protocol, but ideally it's every 2 hours. You want to at least move them a little bit. What if they're not able to move on to one side? Well, what's going to happen then? What if your orders say keep the patient lying flat for 24 hours? How are you going to do that? Pillows, okay, yeah. So you can still get them off of those areas, right? You can adjust the bed. So we have also specialty beds, right? So there's beds that blow air and then release air. So it's constantly moving that air around so they're not having pressure in one area. So a specialty bed would definitely be of importance for those type of patients, right? So you've got to assess the situation, right? Assess what your patient can or cannot do, and then adjust your interventions based on that, right? So yeah, you can adjust the bed. It just depends on what's going on with them and why they have to lie flat. Do they have a head bleed? Do they have too much pressure in the brain and they really can't move at all? You've got to be careful. So those are going to be your patients that are probably going to be on those beds, those airflow beds. So, all right. So again, we already talked about who's at risk for pressure injuries, right? So those same type of patients, those immobile patients, those incontinent patients, those long surgical procedure patients, right? So if they've been in the OR and they've been there for 6 hours, We want to make sure, and just to cover your basis, as a nurse, and you're going to do this a lot, is do an assessment with that nurse, right? So when you get report, you usually go and do an assessment with them to make sure if there was a wound, does it still look the same, right? And then you're going to do your assessment and make sure there's nothing else going on. So you get your baseline when you receive that patient, okay? All right. So factors that influence the development, again, we talked about the amount of pressure or the intensity, how long they've been there, ability to tolerate the applied pressure. Are they one that tends to be have a lot of moisture going on, right? So somebody that is got an infection, maybe they've got sepsis, right? If they've got a fever, what happens when they got a fever? When somebody has a fever, they tend to sweat, right? They'll be sweating all over the place. So those patients are going to be at huge risk. They might be mobile, they might be able to move and do all the things, but their skin's very, very at risk because it's moist because of their fever. Okay. Again, we talked about nutrition, perfusion. You guys haven't gone over this at all, but let's talk about. We talked about oxygen getting to the extremities, right? So people that have peripheral vascular disease or peripheral artery disease, they don't have good blood flow to their lower extremities, right? Their legs. So if they've got, coronary artery disease, right? They got plaque buildup everywhere. Their arteries are just not good, and blood flow can't get past all that blockage. What do you think is at most risk for those patients with bad circulation in their legs? What are you going to look for the most in those patients? What do you think is going to be the most effective body part on them? Their heels, exactly, right? Because the further away from the source, right, from their heart, is not going to get the most blood flow to that area. So no blood flow, no oxygen. No oxygen, no circulation, no healing. It's going to be a cause for a bad outcome, right? So we need to make sure that our peripheral vascular patients, if they're immobile, we need to make sure they're in all the preventative equipment that we have, right? So do we have the boots on them? There's like soft boots that they can wear to keep that pressure off of their heels, right? So again, we look at the bigger picture, right? Who's at risk for developing these? What do they already have going on? Are they on medications that can induce that? Do they have a disease process that's inducing that? How can we implement interventions that can help reduce their risk, right? Or help prevent those injuries, okay? And then again, looking at their comorbidities, we talked a little bit about cardiac, right? We talked about stroke. So any of those patients that come in, you definitely want to recognize. And I think we're going to go over it. There's another scoring system that you'll do for these patients that puts them at risk for, are they at risk for developing these things? So I think it's in the later slides. You guys doing okay? You guys learned a lot already? I know sometimes it can be a little overwhelming. All right. Hang in there. We're almost done, okay? Some of this stuff is very repetitive, though. So again, we talked about the staging, right? So we're going to stage that wound. How far down does it go? And again, we talked about those deep tissue injuries, right? Those ones that go all the way down to the bone. Those are nasty. So we want to stage it. Does it have an infection? Is there anything coming out of it, right? Is it increasing in size? Does it have drainage? All of indurated. What does indurated mean? What does indurated mean? If you're talking about a wound description. Anybody know? Want to guess? So deep thickening that can result in edema, right? Or inflammation. So it's hard. Yeah, exactly. It's a raised area that's hard. Okay, so is it indurated? Does it have any induration to that? Is there a cellulitis? What does cellulitis mean? What does that mean? Again, you guys are going to see this a lot at Cornerstone. Does your patient have a cellulitis? So we talked about those edema, those really edematous legs, right? So a lot of times when somebody has all of that edema and it's weepy, they'll get a cellulitis. So it's an infection of the skin, right? It usually is like really red. They have scaly skin. They're not really getting good blood flow, but they're really edematous, right? Really weepy. Exactly. An infection that makes the legs red and weepy. You got it, Heather. All right. And then somebody with chronic infection, right? So they have sepsis um, and death. That definitely will cause that. So a lot of our patients, especially, again, our geriatric patients that got a lot of comorbidities, they've got a lot going on, they get these injuries and they go from stage 1 to stage 4 within, days. And before you know it, they're not doing well and it's affecting their whole body system. Okay, so we want to prevent that. All right, so going back to stage 3 or 4, so if your patient, again, develops these on your watch, you're part of that nursing team, right? This is considered a serious safety event. You do not want to be part of this. So every place has a quality team, right? And they're going to be aware of all of these things that happen. So we talked earlier when I said, if you get a new admission or you get a new patient report, or you're coming on the beginning of your shift, you want to make sure you do a thorough nursing assessment on your patient's skin. Everybody should get really a skin assessment, okay? It depends on how much you do depending on what's going on. But for the most part, anybody that's in the ICU absolutely needs to have this done on every shift multiple times during your shift as well, okay? So again, if it's a stage 3 or stage 4, it's considered a serious safety event. And you will have to talk to people of why this happened and what did you do to cause it. And you'll have to present your case, and then they'll take it to other committees and determine what action will be taken. Talk about nursing assessment, right? So there's that risk score. We're going to explain to the family what we're doing. So, I'm doing a skin assessment. I'm going to need to look on your back and look in certain areas. It's important, and you can kind of give them ideas why. We want to prevent, and again, what is their learning capability at that moment? Are they able, is that an appropriate time to educate? That type of thing. But for the most part, if you're looking in place or a little private to them, you just want to let them know what you're doing and why you're doing it, okay? Making sure that you're minimizing their exposure, so keeping them covered. A lot of times I'll walk by rooms and the patient doesn't have a sheet on or anything, and I'm like, a little bit of privacy would be the best thing to do for the patient, right? They're already compromised, and that's just not nice. You want to inspect and palpate, right? So we want to, what's the temperature? So we're looking, we're feeling, we're assessing. Is it warm? Is it moist? Is it flaky? Those type of things. What is the color? Does it have a color variant to it? Those type of things. So be as descriptive as possible, okay? We talk about skin turgor, and you guys will hear this a little bit more. Do you know how to assess for skin turgor? What would you do? How would you assess their skin turgor? And what does that mean? Right, you're going to gently pinch the skin. Where are you going to pinch it at? Yeah, it shows the hydration level. It's not a very good accurate one. It's not the best thing, and we'll talk about that in your fluid and electrolyte. But nonetheless, the skin turgor, you're going to pinch either the top of their hand, right, or on their sternum. Okay, if the skin stays pinched or tented, that means that they're dehydrated. They don't have good hydration, right? If it bounces right back to the skin, then that's a sign that they're nice and hydrated. Okay. Again, it's not the best way to tell, but it's something that you can do. The older your patient, especially like your geriatric patients or your patients that are on steroids, their hands are going to do that regardless of how hydrated they are, right? It's just their skin elasticity. So that's why it's not really a good indicator of hydration. But again, it's one of those assessments you can do. And then their skin integrity. Is it intact? Do they have any injuries? Do they have bruising? Do they have multiple bruising in different stages? Like what's going on? Show a picture. So if somebody were to read your note, they can visualize that patient in front of them and know what's going on. Okay. Excuse me. Play, pay close attention to those certain areas. We talked about, those private areas, right? So their perineum area, where are they going to be the most at risk for having skin breakdown, right? Those bony prominences we talked about, any skin folds. So those obese patients that have their pannus is fairly large and it kind of hangs over, you may need to lift those areas, right? Under the breast, under the belly, maybe on their back, maybe on their legs. It just depends. But if they have any type of skin folds, you want to make sure you're lifting that area and looking what's underneath. Okay, there can be deep tissue injuries on arrival, right? And you don't want to have to go into that serious safety event and say, well, why did you cause this? And you say, well, but they came in with it. Well, you didn't document that. So you want to make sure that you're documenting appropriately too. Okay, so again, document, document, document. Can't do enough of that. Okay, so integration of skin assessment in your workflow. So you can always do a skin assessment as you're working with your patients, right? So if you're applying oxygen, check their head, check their face, their ears, okay? Especially patients, our COVID patients now that are on oxygen and that high flow oxygen, or they've been intubated for a long period of time, they've got such skin breakdown on their ears, the tip of their ears, the tip of their lips, their nose area, all where that tubing, you can imagine, right? It's around their face, around their head. Anywhere that's touched for, just a few hours too long and we haven't moved it, and they've got COVID, that puts them at a high risk for those skin breakdown, those skin injuries, right? So again, checking it, every time you're in there with that patient, you're checking whatever you can look at, okay? IV sites, you're always looking to make sure your IV's in the right place, right? We don't want to have an infiltrate because that's going to cause an issue with the skin, right? Especially if medication's going in it and that medication's not supposed to be in that space and it can cause that skin to slough off, right? So you guys will learn about that too. So making sure that those are all intact. Removing any equipment that doesn't need to be there, right? Do they have a bunch of linen underneath them that's all folded and kind of all in a ball, right? We need to smooth that out. They can't be lying on that because that will definitely cause skin breakdown, okay? So while you're doing your general assessments, you can definitely assess the skin. All right, so the Braden scale. The Braden scale, again, is going to be a tool that's going to be used. I believe all patients, they get a Braden score on admission, right? And it evaluates them and their risk for developing the skin breakdown. It's the most preferred tool, and there's 6 categories. I'm not going to go into detail. I just want you to know that the Braden score, if you ever hear that, which I would know that, the Braden score is a scoring system to evaluate the patient's risk for developing pressure injuries or skin issues, okay? They look something similar to this. You kind of go through each of the topics. So sensory perception, texture of their skin, what's their activity level, what's their mobility level, nutrition level, that type of thing. So in this sense, the lower the number, the higher the risk the patient is for developing a skin issue, right? So you can see these are very limited, they're bedfast, they're very poor, they've got problems, and over here they're excellent, they've got no limitations. So again, take a look at your facility and see and check and see. I want you guys, when you go to clinicals the next time, look for 2 scoring systems, right? Do you remember what that first one is? What's that first one that we talked about? A pain scale, right? You can look at the pain scale. But we talked about the depression scoring or their suicide risk, right? So see if your patient has been risk stratified for suicide, okay, and what that looks like for that facility. And then I want you guys to look at if the patient has a Braden scale, okay? Take a look at that as and know what your patient's Braden scale is. know what risk, how high of a risk are they, and then when you go and do your assessment on that patient, see if any of those things are an issue, right? What's underneath my patient? Do they have IV tubing wrapped around their arms and under their back? When you do your skin assessment, do you see anything? Is there any redness that wasn't there before? So know what the assessment was prior, and then when you go in there and do it and compare the two. Okay, so that's what you're really looking for. Okay, so those two things I think you guys need to do. And again, we kind of talked about the scoring, right? So the lower they are, the higher risk they are for developing these things. I'm not going to go into all the interventions. You guys can go through that in your book, and we kind of talked about that, right? Managing their moisture, positioning their extremities, those type of things, using the devices, using the beds. There's different. We talked about the different beds available, those type of things. Okay. So our goal for nursing is we want to maintain their skin integrity. Okay, we want to prevent this skin breakdown from happening. So we know all the things that we should do, right? If we have these high risk patients that are what we talked about, we want to make sure that we're implementing all of the things that we can to make sure that we're preventing any skin from breaking down. Okay, so again, this is all the things that we've talked about already. All right, you guys, we're almost an hour over what we scheduled for, which is totally fine. There's some practice questions here. I think what I'll do is I will leave. Do you guys want to go over this, or do you guys want me to just put this? It'll be in the announcement page. You guys want to go over this on your own time? What do you guys want to do? I'll leave it up to you. You guys kind of done? Let's see. We're on slide 27 and it goes to 33. So I don't think there's very many. We'll do this. I'll keep recording. We'll go over it. Those of you that want to jump off, feel free to do that. And those that want to stay, go ahead and feel free to stay, okay? So we'll go through some of these practice questions. And if you guys need to go grab a drink, I know my throat is super dry. So grab yourself a drink real quick. Yeah, I'll stay on for questions after class, and feel free to ask your questions here in the chat too. And if we're talking, you can go online too and ask a question. Oh, next lecture. Yeah, we'll go over that. We'll go over that. Now that you guys have your schedule, we kind of have an idea that I think for the most of you guys, your schedules look open. It looks like you guys have class Monday, Tuesday, and Sundays. So it looks like we might have like a Wednesday and Thursday kind of open. Yeah, let's go through these practice questions really quick, and then we'll talk about moving forward, because we have Professor Plank, who's also going to be teaching some lectures. So I need to get with her, and we need to make sure that we're being consistent with the time. And so let me do this. I'll send out an email when we decide, when we have that plan of what day we're going to do. And kind of keep it consistent, okay? So that way you just expect an email with that information, okay? I don't want to keep you on longer than you need to be. Okay, all right, let's go through the practice questions. All right, so let's have somebody read the question. Who wants to read it?
I can read it.
Perfect.
A nurse is providing care for 4 clients on a medical surgical unit. Which of the following clients should the nurse identify as being at risk for the development of pressure ulcers? Select all that apply.
Okay, so let's go through those. So in the chat, you guys will answer A, B, C, D, or E, right? So who wants to read the answers or go through the answers? You guys can start chiming in if you already have an answer. who do you think? So you're caring for a patient. A nurse is providing care for 4 clients on a med-surg unit. Which of the following clients should the nurse identify as being at risk to developing these pressure ulcers? So we talked about who's at risk, right? So a client who is ambulatory following a cardiac catheterization 4 hours ago. Why are they not at risk? What are 2 things that point out to you that they're not at risk? There's 2 things in that statement. They're ambulatory, right? And what else? So ambulatory means they can walk. There's another part of that piece in there that kind of tells you that they're not as at risk 4 hours ago, right? So it's only been 4 hours, right? We want to turn them every 2, but 4 hours is not that long. But they're also mobile, so they're able to kind of move around in that bed, right? So that would not be one that you choose. A client who has type 1 diabetes and is hyperglycemic. Did you guys choose B? So, I mean, yeah, you can say they're at risk, right? So diabetics are always at risk. It doesn't mean that they always have necessarily anything concerning, right? And they're hyperglycemic, they're definitely at risk. Developing those ulcers. Yeah, that's what the question's asking. So yeah, sorry, yes, B is correct. So those patients are at high risk because they're diabetic, right? We talked about those diabetic feet. They can't feel, they have neuropathies, right? And then hyperglycemia. Why is hyperglycemia, what does that cause when they're actually hyperglycemic? What happens when they're hyperglycemic? Or they kind of live there, right? They're just at risk for infection. Their immunity, their body doesn't heal as fast, or sometimes at all when they're in a constant state of hyperglycemia, right? All right, so B is definitely one. And then a client who has a protein calorie malnutrition. You guys choose C? Some of you did. So definitely C, right? We talked about protein being a huge factor. If they're protein deficient, so malnutrition means that they are deficient, right? That's definitely one that you want to choose in that equation. A client who has right-sided heart failure and 4+ edema to the lower extremities. So you guys haven't learned this yet, but some of you may know. If you have right-sided heart failure, the right side of your heart is going to back up, right? It's going to clog that pathway to going into the lungs, so it's going to back up into the lower extremities. So they're going to have a lot of edema, and in this case, he's got 4+ pitting edema. Okay, so that's one of your assessments when you do your skin. How bad is that edema? And you basically push into their skin, and how far in does it go and how long does it last, right? So that's pretty significant edema. Are they at risk? You guys choose D? Yep, exactly. They're going to definitely be at risk. And a client who is who has post-operative delirium. No, right. And why not? Why would they not have it? There's no indication. Right. Perfect. I love that answer, Christian. No indication. So just because they're post-operative, if they already have a wound, right? We're talking about pressure injuries. So I always have to go back to that question. What are they asking me? And we're talking about pressure injuries, right? So when you're reading that question, again, the things that you want to pull out of there is risk for pressure ulcers. Okay, who's at risk? So yeah, you're right. There's no indication. Absolutely. All right, good. All right, so number 2. So what action would be most helpful in preventing pressure ulcers from forming in an at-risk client? So what's going to be most helpful in preventing the pressure ulcer formation in an at-risk client? A, repositioning every hour. Right. Perfect. B, that is incorrect because why? We want to increase their protein intake, right? Exactly. So some of those questions you guys just got to be paying good attention to. Don't read too fast because you might miss those key words, okay? And that will throw you off. So you don't want to choose the wrong answer because you thought it said this, okay? So yeah, low protein. Ensuring generous fluid intake. So we definitely want to make sure our patients are hydrated, right? But is that going to help prevent them, right? It's not going to help prevent them. Yeah, it could lead to other issues, right? So edema or heart failure that causes other things. Doesn't say that in there. We don't want to read too much into it, but that's not going to prevent that, right? We want to massage a red area on the sacrum, and it talks about that in your book. Yeah, absolutely not. Do not massage that area of redness. Um, does anybody have that in there? There's a, uh, anybody want to read that rationale?
The rationale in the book because we can't see that.
It should be in the readings. I'm trying to find what page that would be on. So it talks about things to not do with your wounds or to avoid, and that's definitely one of them. Let's see. Let's see. I would definitely, when you go back into your readings, look at that and understand that, but definitely you do not want to ever rub anything red because it could be something else, right? So what else? And again, something that we haven't really talked about, but what else could you think of that would be causing redness to an area? First of all, yeah, you're right, Alice. It's going to hurt, right? So they definitely don't want to massage there. It's going to hurt them so bad. Right, it could be an infection, right? What if they've got some like clotting issues going on and we've just dislodged a clot, right? That could happen as well. So anytime an area looks a little red or inflamed, you definitely don't want to massage it, okay? All right, very good. All right, so number 3. A nurse is assessing a group of older adults. Which client is at risk for skin breakdown? A person who has A, B, C, or D. So the things you want to pull out of that statement, who's at risk for skin breakdown? B, reduced sensation of pressure, right. Altered balance, I mean, what are they at risk for? Somebody's altered balance. Falls, right? Exactly. Impaired hearing. Hearing has nothing to do with the skin, right? Visual acuity doesn't really have anything to do with skin breakdown. Unless they can't see, then they fall, and then now they've got a skin issue. That could definitely lead to it, right? But not a risk factor for skin breakdown. So, yep, very good. All right, so number 4. All right. A client from a nursing home arrives at an acute care facility for treatment related to complications of chronic obstructive pulmonary disease. A nurse performing the admission assessment notes the presence of a large stage 3 pressure ulcer. The client's child asks if the hospital can, quote unquote, treat the sore. What is the nurse's best initial response? A, B, C, or D? Give you guys a few minutes to read through them. What's the best? So here's a great example of a great nursing question, right? There's probably a lot of right answers in that in those answers there, but what's the best response? What's more orange? So I've got 2 Ds. Okay. So yeah, so let's walk through that. So A says, I'm not sure what you know about this type of skin problem, but I will try to stop it from getting worse. Well, that doesn't really give too much hope, right? That's kind of, oh, I know it's there and I don't really know what you know about it. So that's really not appropriate, right? We don't want to give them, because we don't know that we can stop it from getting worse, right? I don't know how real bad it is, how deep it is. Is there any tunneling? Is there, what else, what other factors are going on in that with the patient? It's unfortunate that the client has this sore. We will have to file a report about it. Nobody needs to know that, right? Yes, it probably will happen, but again, not the best answer. As you can see, the wound is fairly deep and may need debridement. So again, you don't know that at this point, right? So yes, it probably will need that, but again, not the most appropriate statement for a family member. So D, we will collaborate with the physician to obtain an order for the wound care nurse to see that client. So basically, yes, D is correct. And what you're saying in that statement is that we're going to have, the wound care specialist is going to take a look at it, and we're going to see how we're going to treat that. Because there may be different options, right? We may do hyperbaric. She may need just a dressing. She may need, sharp debridement, those type of things. So we really don't know what that's going to look like. Okay, so I always say if you don't know, err on the side of, well, we're going to, talk to the physician and come up with a game plan. Okay. Because if you tell them debridement and you don't do debridement, they're going to question that. Unless you know for sure, right? But again, what's the best answer? All right. Number 5, the nurse is bathing a client and discovers a pressure ulcer on the buttocks. Which nursing intervention following completion of the bath is completed first? So what are you going to do with that patient? A, B, C, or D? You just gave them a bath. You notice the ulcer. And what are you going to do following the completion of the bath first? A, so position the client off the ulcer. Exactly. Again, we're not going to massage any ulcerated area vigorously. No, no, no. Place an antibiotic cream over the ulcerated area. So if you just identified it, right, more than likely you're not going to have any orders to do that. So you don't want to work independently off of orders that you don't have. Notify the healthcare provider and await orders. That's a right answer, absolutely, but it's not going to be the first thing that you do, right? So imagine you have this patient in your hand that's, just had a bath. What are you going to do first? So yeah, A is the correct answer. Okay, last one. So while caring for a client who's immobile, a nurse documents this information in the client's chart. Turn client from side to back every 2 hours. Skin is intact, no redness noted. Client up in chair 3 times today. Improved skin turgor noted. Which nursing diagnosis accurately reflects this information? What do you think your nursing diagnosis is going to reflect all of the information provided? So B, okay, B. All right, so this is a really good question. So I want you guys to go back into the assessment, right? So here's when you're looking at the questions, you're going to ask yourself, when you're nursing, you always do an assessment. After your assessment, you do an intervention, right? And then after the intervention, you go back and you reassess. Was my intervention effective? Or do I need to do something different? Okay. So when you're reading these questions, you're going to say, is there an assessment here that I already have? Is there an intervention I need to do? And do I need to go back and reassess? Okay. So this is a perfect question. So B is actually incorrect. Okay. And why is that incorrect? Go back to your assessment and tell me, I'm going to pick on somebody here. Elizabeth, you want to read what your skin assessment says in the statement? Or anybody that's available that wants to. Right, the skin is intact. There's no redness noted. So what are we supposed to do with our immobile patients, right? We're supposed to turn them. So we talked about that Q2 hours, right? So it looks like they're getting that. It's charted that the patient's been turned side to back every 2 hours. Check, good, we've done that. The skin is intact. There's no redness. The client is actually up in the chair 3 times today. So they're actually moving around. They're getting off of those bony prominences. They're moving around. They're getting that circulation going, right? They've got improved skin turgor. So they're having some improvements, right? So maybe they're a little dehydrated before. So when you look back down on your nursing diagnosis, are they at risk or do they have impaired skin integrity? They're at risk, right? So they're still at risk because they're still a patient. They still are immobile, and we need to make sure that we're continually doing those interventions to make sure we sustain that preventative um, uh, action, right? If their skin integrity was not intact or they had anything that was impaired in that statement, then it would be impaired, right? If they had some redness, if the patient did not turn every 2 hours, those type of things, right? So that would be where you would say it was impaired, okay? So again, when you read the question, you may have to go back to, to reiterate what are those key things that you're taking out. So when you're reading that, you're going, okay, that's a good thing, that's a good thing, that's a good thing. I got nothing going on with the skin, right? Yes, they're immobile, but everything is intact. So you don't have an actual issue, right? We don't have an acute or impaired skin at this moment. Does that make sense, you guys? Okay, perfect. So I will tell you, okay, this is the last slide. So we'll have one more lecture next week before your exam. And so um, get all your readings up to date. Make sure you can, go back into the chapters, do your quizzes, your quiz again. And then that way next week when we go over module 4, you'll be prepared to take that exam on Friday, okay? So make sure that, again, just getting all of your readings done and all of that, and your assessments done, your case studies and your practice questions. When you take your exam, there's typically 60 questions. You have 1 minute per question. So if you have a 60 question exam, that means you've got 60 minutes. So in the announcement page, I posted the schedule. So the first exam is Friday the 24th, and the exam starts at 1 p.m. Okay, so that means you need to be ready to go 15 minutes before the exam starts. Okay, we'll email you your passcode. You're going to plug that passcode in, and then at 1 o'clock it's going to open for you. Okay, so be ready to go. Have your camera on, have the lighting on, all of that stuff ready to go. Okay, you'll have 60 minutes. So my whole point of this is you're not going to be able to spend a whole lot of time on one question, right? You need to kind of move through it fairly quickly. So when you're doing your practice exams, I want you guys to start timing yourselves, okay? So timing, see how long it takes you and start to build that up to where you're comfortable reading through it, but able to pull out that key information, right? So it's going to take some time, it's going to take some practice, but that's why we have all these practice questions, right? So that you can better prepare yourself to be able to pull that key information out of the question, look through the answers, and be able to completely eliminate some of them, right? Like you can immediately disqualify C and D. So you're you're talking about skin integrity, and then looking at what's the difference. Are they at risk? Are they impaired? And know that difference, okay? So again, it's just practice makes perfect, okay? And like I said at the very beginning of lecture, there's going to be more to come if you guys haven't already got Exemplify. Has anybody downloaded Exemplify onto their computer yet? Okay, good. Okay, perfect. Perfect, perfect, perfect. So yeah, so that computer, wherever you downloaded that from, is going to be where you take your tests. So again, make sure that you have it all ready to go for next week. Are the quiz questions a good indicator of the kinds of questions? So they're not going to be the same for sure. It's going to be kind of an ideal of how the questions are going to be asked more than the content, if that makes sense. So everybody always asks me, do you have a study guide for it? Like, out of all of these chapters, you guys could probably have 500 pages that you've read for the first 4 modules, right? What do I really need to study? And my answer is always going to be, you kind of need to know it all, okay? You're going to be taking care of these patients. They're going to be completely in your care. And so you'll be the expert in nothing, but you'll know how to take care, or at least know the direction of what you need to do. Okay, so you need to be able to appropriately assess your patients, know what's going on, and be able to prevent any harm to your patient, right? We always want to make sure that we're keeping them safe. So again, when you're going through your readings, be intentional, understand what you're reading. If you don't understand it, stop, take a minute and go back to it. If you're still stuck, you can always reach out to myself or to whoever your professor is. And then we also have tutoring online, right? So if you're just really stuck and you're just not comprehending what the process is, or the pathophys behind it, or whatever that looks like, reach out. Don't sit stuck for a very long time, okay? So again, I can't stress enough, read with intention. Will we have a review for next week's lecture, or is it a continuation lecture? Alice, what do you mean?
So if our lecture for next week will be content for the Friday exam, or is it just like 1 week ahead? If that makes sense. Like,
so next week will be the lecture will be covering module 4,
okay,
right? So that's part of the exam. So
okay.
so you'll have your exam, and let me make sure I'm saying this right because I got to look at my calendar. So next week we'll figure out the lecture day.
Mm-hmm.
It'll either be Wednesday or Thursday, and we might make it Wednesday just to give you guys that buffer for Thursday,
Mm-hmm.
and then exam is Friday. So it's going to cover the content that you just got lectured on Wednesday.
Okay.
So again, time management, right? So you don't want to wait last minute to read all your content, to understand it, to do the practice questions and so forth. You want to have an idea, of everything. Come prepared to class so that you're ready to go on Friday, because you're going to have 4 modules that you're going to have to go back and remember and review, right?
Yes, and then I had just one more quick question.
Uh-huh.
On your schedule, there's like, for example, chapter 14 is depressive disorders, which are, our readings for this week. And you
Uh-huh.
have like the page numbers of like what pages exactly to read, but that it just doesn't match up to like the full chapter. Are you just wanting us to focus on those specific pages of that chapter?
Yes. So if you're in Blackboard, right,
Mhm.
and you're looking at the modules, let me see, let me get to that. Yes. So there are going to be some times in your book, like even the module that we're on right now in the Lewis book, there's not going to be everything that you're going to read. So it's not going to be the complete chapter, and there might be even skipped things. So it's only the pages that are listed in Blackboard that you're responsible for. Okay.
Okay.
Any content outside of that, we're not going to cover in any exam and expect you to know.
Okay, sounds good. I just want to double check if like I got the wrong edition of the textbook or something, but I just wanted to make sure. Thank you.
Yeah. You're welcome. And that's something I'm going to look at. It was brought to my attention about, where is it at? It says 10th edition in your Lewis reading, the book, but it's the 11th edition. So all the chapters are correct. I went back to look today and I was like, oh my God, is this like the wrong pages? But it is correct. It just has the wrong edition. But you guys should all have the Lewis book edition, the 11th edition. So I need to change that in Blackboard. That's the only thing that's incorrect. Okay. Yes, Ava, the modules 1 through 4 is going to be your exam for Friday. Heather, you asked, can you go back to a question? Which question do you want me to go back to?
I just mean like if there's something that's giving me trouble, can I move on to that one?
I'm sorry, you're really breaking up.
That's it.
Can you type it in? Because I can't. You're breaking up really bad. If you type it in, no worries.
It sounded like she might be asking on the exam, if you skip a question, can you go back and answer it later so you're not taking up all your time?
Oh, let me get back to you on that because I know we used to, and I think we stopped doing that, but let me verify that. Stop and go back. I will email you guys with the right answer, okay? I want to say yes, but I don't want to tell you the wrong thing and then you do it and then you're stuck and you can't go back. Any other questions, you guys? You guys learned a lot today. So you can kind of see how the content's starting to build up a little bit and we're kind of building that foundation, right? So get ready. Yes, it's all going to be multiple choice questions. Select all that apply, absolutely. And it'll tell you in there if it's multiple choices, if there's multiple answers within that question. So all for semester J1, in theory, it'll be all multiple choice, okay? Yeah, I do. And I think that's why we went back and forth on it, to be honest, with the testing. So yeah, I do agree. But sometimes too, you don't want to get hung up on something too long and kind of have it linger and then you kind of, you can get caught in that situation as well too. So, and you guys will get, as you do more, you'll get better at test taking and how all that works, and nursing questions are definitely different. So again, I think this number 6 right here is a perfect example of that. Yeah, you can't go back on NCLEX. So absolutely right. So yeah, we definitely, the whole purpose of all this, right, is so, to put you through all of this. It's not just to really give you those hard questions, but it's to make sure you're successful at the end of nursing school, right, to be able to pass your boards. So that's the whole idea of it all, right? So um, the first exam is always, it depends. So the first exam is always the toughest, right? It's the easier content, but it's the first time you guys are taking nursing questions. So there's three, I'm sorry, there's four J1 students. So there's 3 classes of ABSN students, and then we have one traditional class of the traditional track students, right? So y'all are going to get the same test on the same day. And so all 3 of us instructors are going to go over after you guys are done with the test and review. And just sometimes there's questions that we can throw out based on maybe the question wasn't if everybody missed it, we'll definitely like throw some questions out. So I would say, it's kind of split. There's some that do very well and there's some that don't do very well. The ones that don't do very well don't use their resources. They don't do the practice, they don't do the reading, they don't reach out when they're stuck, if they're not understanding the material. Sometimes, well, a lot of times, let's say you don't do very well on the first exam because it's just new, right? And you just are not a good test taker, or whatever the reason may be. If you change your study habits and you change the way that you're reading, and you really have to make those changes quick, you cannot sustain passing if you don't change those habits. Usually the ones that fail continue to fail exam after exam, if that makes sense. So again, the first one is a little tough. The material, like I said, is the easier part. It's just taking the test. So the more you can practice those questions and the more you can do, the better you'll be prepared to be able to read through them and know what you're looking at and knowing how to exclude some. All right, you guys. That's all I got for today. So I'll post all this stuff on the announcement page. Um, I will get back to you. There's several things I'm going to get back to you guys on, and I'll send that in an email. And have a nice day, you guys. And if anybody has any questions, I'll stay on just for a few more minutes. So you're welcome, you guys.